Right, this afternoon we've got Dr. George Finidori and Dr. Dana who are going to speak with us. So if you'd like to take your seats, we'll get going.
Okay, thank you very much. We are very happy to be there with you. I am working in team with Dr. Dana, who is an orthopaedic surgeon. We are both working in the Hôpital Necker in Paris. And as for me, I am concerned with bone constitutional disease for many years now. I am more or less retired now, and I am working with young surgeons who are taking my job and who will follow me. It's very nice to have such followers. I think it's very important to share experience, and we have been working in Paris. Mainly the main man was Dr. Marotto. Dr. Marotto is still living. He's an old man now, and 60 years ago he was very involved in the bone constitutional disease, and he was making a tremendous work in this field for classification and to recognize many diseases. Then I had the opportunity, and it was a very nice experience for me to work with this man during 20 years. But there is a lot of surgeons in Paris who were concerned by this bone constitutional disease. The previous one was, and who are old now, was Professor Rigaud and Dr. Padovani. And there is many others, and young one like Dr. Dana, who is very concerned. For the genetician and the pediatrician, there is also a huge team who is concerned by this pathology. We work in, we have organized at the beginning a pluridisciplinary consultation with genetician, pediatrician, and orthopedist. And secondary, more than 10 years ago, we have organized a national reference center for skeletal bone dysplasia with, in Paris, 4 hospitals, 2 for adults, Hôpital Lariboisière et Hôpital Cochin, et 2 hospitals for children, l'Hôpital des Enfants Malades et l'Hôpital Trousseau. We have between us a short connection to treat patients, young patients, and to treat them after when they have become adults. And we have also organized a competence center all over the country to try to improve the treatment of this kind of pathology. And there is many bone constitutional disease, about 300, and Ollier and Maffucci syndrome, of course, is a small part of this huge system of pathology. Then we have, nevertheless, an experience from a lot of patients, and we will try to show you our experience in the treatment. We are both together pediatrician, but we will try to speak also a little for the adult patient, and we will also speak a little about our team, the research, and the organization. Dr. Dana speaks much more better English than me, and she will explain everything for you. She just wants to make a joke, to say that there was old one and new one, then new one will explain to you everything.
As George was saying, we're really orthopedic surgeons, so I won't speak a lot about what is Ollier disease, because I think you guys know already a lot of things, and we have other presentations that will be much more complete. So So our job is really to take care of orthopedic treatment in children, and then I'll try to speak a bit about adult treatments also. So usually we discover Ollier disease in a child that's around 2 or 3 years old. Often it's discovered with bowing of a bone or leg discrepancy, like you can see on the picture. This little boy has tibial bowing, and he's starting to have a leg discrepancy. Sometimes it's discovered with swollen fingers. Other times it's unexplained pain, abnormal fractures, and the Ollier disease is asymmetrical, which is one of the particularities. The x-rays are pretty typical, so it's not very difficult to make the diagnosis. We can see clear bone lacunas that are going to appear near the growth plates, so in the proximal part and the distal parts, and usually the medial parts of the bones are more or less normal. Then, as you can see in this little girl, often the disease can start in the fingers, so we'll have like swollen fingers that are a bit deviated. And on the x-rays, we will also find inchondromas that are going to be in the distal part and the proximal part of the phalanx. In children, fractures can occur. Usually they don't occur in the parts where there's most chondromas, because they don't occur in the proximal and distal parts. They will more occur in the medial part. This is explained because sometimes you have small chondromas that are going to make a gap in the cortical, which is the strong part of the bone, and this is going to be like a zone of fragility. So the bone will break at that place, like you can see in this picture, where in this x-ray where the bone did not break in the part where there's the most chondromas. We can also find chondromas in the pelvis, and the chondromas can also develop on the ribs, but usually in Ollier disease you don't find chondromas on the spine. The clinical presentation can be very different, and you guys are probably aware of that, but some people can have only a few chondromas limited to one hand, and then other people will have more severe forms with very numerous and disseminated chondromas. To do diagnosis, it's mostly clinical. We don't need a lot of exams. We use x-rays to follow children, but we try to be the most, I'd say, we try to limit a lot the use of x-rays, because we know that Ollier patients will be radiated during their whole life. So as we were speaking a bit earlier, we have the Eos Imaging system that has come out in France, and which allows to do total body x-rays with much less radiations. This will allow us to screen every location of chondromas for one patient, and then if we need to follow up one region, we'll use MRI. But for children, we don't use total body MRI. This is not our practice. Scanner will only be used for pre-operative cases if we need to really know where the chondromas are, but we don't use that for practice in children because it radiates a lot. And finally, scintigraphy for Ollier disease is not an exam that's very good because it doesn't bring anything more than MRI. We don't use biopsies for diagnosis. It has no utility to do the diagnosis of Ollier disease. But when we take away chondromas during surgery, we always do a tissue analysis but it doesn't help us to do the diagnosis. It's only clinical and on x-rays. There are a lot of diseases that look like Ollier, and as George explained, as we are specialized in bone dysplasia, we are confronted sometimes to see patients that have Ollier diagnosis, but that in fact are other diseases, because sometimes there's a bit of confusion. So I'll just show you a few examples of diseases that are probably part of the same family, except today the research is not very advanced. But we can see that there's a link between these diseases, and some resemble a lot to Ollier disease. And for example, this disease, which is very rare, but very close to Ollier, is the spondyloincontomatosis. All these diseases have names that are a bit difficult. The clinical presentation is very similar with inchondromas that on the limbs are really close to Ollier. The big difference is the spine involvement is very important, whereas in Ollier there's usually no spine involvement. This is another disease. I won't name it because it's a bit awful, but it's also rare. Just to say that it also has inchondromas that are close to the growth plate. The difference is also the spine involvement, and also it's a disease that affects the growth plates much more than Ollier, and so it's people that are very short. There's little kids that they don't grow very much, so they are very small at adult time. Then there's the multiple hereditary isostosis, which is very different, but sometimes it can be confused. So there the bone formations are outside of the bone and not inside, like the Ollier. So people have also sometimes swollen fingers and balls that appear, but it's very different in the x-ray, and it's bony formations and not cartilage. The metachondromatosis also presents with swollen fingers, but the difference is that on the x-rays it's more like bony formations that are also close to the growth plates, but they're not cartilaginous. And on other locations you also have inchondromas, but that are outside the bone and not inside, like you see on the feet here, or here on the ankle, it's outside of the bone. But if you look at the x-ray of the pelvis, it's very close to what we could find in an Ollier patient. So sometimes there can be confusion. Fibrous bone dysplasia, it's the bone tissue is replaced by fibrous tissue, which is going to fragilize the bone, make it bow, and also you can have fractures. And this pathology can sometimes be found in some patients associated to Ollier. So we have a few patients that we follow that have the diagnosis of Ollier, but in fact in some of their body parts we found some parts that are not inchondromas and that are fibrous dysplasia. So all of this means that these diseases are part of a larger family, but for the moment, so we're doing a lot of research on that, but it's obvious that we will find links between these diseases. This is almost the last one. This is a very rare dysplasia. It's just to show you that it's on the tibial x-ray. It really resembles an Ollier. It's the same thing, except the only difference, it's dysplasia that is only going to affect one tibia. So it's a bit weird, but the aspect on this tibia is going to be the same as Ollier. And finally, this is the last one, I promise. It's the hemimelic epiphyseal dysplasia, which is going to have inchondromas that are in the joints, But, so it's different presentation, but actually in the tissue analysis, it's the same tissue as in Ollier disease. So finally, to speak about the treatment, which is more our interest, we, as George talked, try to organize patients in specialized consultations, and we really think these diseases should be treated in reference centers. We do yearly surveillance for our children, so children are seen every year in a multidisciplinary consultation. We use very little imagery. It's more clinical surveillance, and if we have one particular thing that bothers us, we use imagery. And finally, to speak about evolution and prognosis, this is very different from one patient to another, so we can't give a global prognosis to a parent. And what's important is to see the child every year, and then we have an idea of what type of Ollier disease we're in front, if it's going to be a severe form, or on the contrary, a less severe form, and then we can inform patients. But it's obvious if we only see one patient once, it's very difficult to give a prognosis, because it's not like that it functions. Unfortunately, for the moment, we don't have any curative treatment, so our job is to deal with complications, and we mostly use surgery for that. In children, fractures are more frequent than in adults, probably because they're more fragile, but also because they're more active. We don't have any problems of consolidation in Ollier patients. They consolidate well. So we use classical casting in a lot of fractures. We don't always have to do complicated things. On the other hand, when you have a patient like on this x-ray that has a very fragile femur with a fracture, it's sometimes better to do a more complicated surgery, because you need to protect the bone from future fractures. So in these cases, it's interesting to use intramedullary pinning to treat the fracture, keep the bone aligned, and also avoid other fractures. And these systems grow with the child because they have a telescopic system. You can also use a telescopic system on the forearm to avoid also future fractures. Children will also be very affected by axial deviations, because the enchondromas are going to affect the growth plates. So we have to treat these deviations. When we do simple osteotomies without any material, like in that x-ray, often the deviation will come back, because you have to understand that we don't treat the disease, so the disease continues. So sometimes it's better to avoid those types of surgeries and do heavier surgeries to avoid the bone to come back. So we're going to use material to avoid, to protect the zone of enchondromas and to avoid secondary bowing. So this patient had plate used, but we can also use more simple system. This patient had staples that were used to hold the osteotomy. But now in children, the technique we use the most is also intramedullary pinning to correct deformities. This little girl, for example, she has a femur that's bowing. She has fragility, but because the bowing plus the enchondromas are going to really make a fragility zone in her lower part of the femur. So, and she also has a big discrepancy. So we have to try to treat everything at the same time. And we have to see all the problems together, otherwise it doesn't function. So for this little girl, the idea was on the side that was bowing and that was short, to make an osteotomy, but also to do an intramedullary pinning to protect her bone, avoid future deviation. And then on the longer side, we performed blockage of the physial plate, of the growth plate, so that her leg discrepancy would lower with growth. This is another example of a severe Ollier patients with both legs that were very deformed and very fragile, who was in which we used telescopic nails to protect the bone and also to avoid bowing. Some patients will have other symptoms. For example, this is a humerus, and this child was very painful because when the bone is very fragile, it has multiple stress fractures, and so these patients have a lot of pain, and also they're always afraid of breaking, so their life is not very easy. So in these cases, doing intramedullary pinning is recommended because it will protect the bone. It will also, most of the time, take the pain away. And also, if you look at the pictures, once we do the pinning, usually the chondromas start condensing a bit, and the bone gets less fragile. It's the same thing for the tibia with a patient with a stress fracture that you can see in the middle of the bone. And it's the same principle. We do a simple pinning. There's not many. It's a simple surgery, and it allows to relieve pain and protect the bone. As we talked a bit earlier, leg discrepancy is also a big problem in children with Ollier. So we can do and because we can associate both techniques. We can block the longer part, or we can perform limb lengthening in the shorter parts. And in severe forms, often we have to do both. So we use a technique of epiphysiodesis with using two crossed screws that are placed under X-ray exam, and we only do little incisions, but there's many other techniques to block the growth plates. Some people just do a curettage of the growth plates, which is the line you see on the X-rays, which doesn't exist in adulthood. This is a patient that had multiple problems. He had a femur that was fragile. He had bowing in his femur. And finally, because of all this, he had a fracture. And so we decided to use the fracture to correct the bowing and try to correct also his leg discrepancy that was present, not very important, but that was present. So we put an external fixator, which allowed to do limb lengthening and correct the bowing, and also obtain consolidation of the fracture. And this is his patient. So this is when he was little. So you can see he was obliged to wear a splint to protect his femur, and he had a leg that was pretty deformed. And this is the X-ray afterwards, and this is him at an adult age, and he has a pretty nice result. So, you have to know that lengthenings in Ollier disease is something that is, I'm not going to say easy to do because it's never easy, but compared to other disease, it's pretty much easy for us because Ollier disease only affects the bone. It doesn't affect muscles or tissue or other surrounding tissues. So when you do the lengthening, the tolerance of the tissues that are around the bone is going to be very good. And also, usually these patients consolidate well, so we don't have much problems of consolidation. The only problem we have is fragility, because when we perform lengthening, usually the bone is still a bit fragile afterwards. And as you can see in this patient, the discrepancy is very severe. So we have to associate all the techniques we know how to do. So we're going to block the tibia, the femur on the longest side, and then we have to perform lengthening in the femur and secondary lengthening in the tibia. So it's pretty heavy, but it allows the patients to arrive in adulthood with a good result, because otherwise it would be much more. This patient had lengthening on the femur, and finally he was left a bit too fragile on his femur, so he had a stress fracture that occurred a few months afterwards, and that's why you can see on the last x-ray that he has intermedullary pinning, because we were obliged to do that to protect his bone. So sometimes now what we do is we associate lengthenings with intermedullary pinning to protect the bone. So we put the external fixator, and we're going to do the lengthening using the intermedullary pinning to protect. And once the lengthening is finished, we keep the pinning inside so that it will protect the bone. The upper limb will also be affected by incudomas. So usually a forearm, you have the radius and the ulna. The ulna should be longer than the radius. But in most patients with Ollier disease, the incudomas will disturb this forearm, and the ulna will become shorter than the radius. And we know that if it becomes more than 2 centimeters shorter, then the radial head that's in the elbow that you see over there, here, will dislocate. So usually we try to treat patients early in lifetime to avoid this dislocation, because the dislocation will be painful and will affect elbow function. This patient had already had his radial head that was dislocated when we took him in charge, because the ulna was very short. So in that case, we were obliged to do ulna lengthening, shortening of the radius, and the radial head was removed because it couldn't be reintegrated. Finally, the results was good, and he had good elbow function. In this patient, the radial head was starting to dislocate because the ulna was getting a bit too short. So there we did a preventive treatment, and so we lengthened the radius, lengthened the ulna, shortened the radius, and reintegrated the radial head, which is the best situation. The humerus can also be short, but usually it doesn't bother really patients, so it's very rare for us to treat short arms, but it's possible to do lengthening if we want to, but we rarely do it. For digital chondromas, we think it's good to operate patients young, because when you operate young, you can avoid joint stiffness. If you operate too late, then the stiffness will not be recuperated after surgery. We have a very simple technique where we open the phalanx, we curtage the chondromas, and then we collapse the walls of the phalanx, and this is going to provoke a remodelage of the phalanx, and we don't need to graft the phalanx. There you can see this little girl that when she was little, so she had her phalanxes that were had a lot of inchondromas. So she was treated by this technique, and there's no recidivism, and at that stage her phalanxes are almost normal. When it's later, the stiffness and the inchondromas are much more important, And so we can still operate, but the problem is the fingers will look better, but they will stay stiff and function will be much more impaired. In children, sometimes you can have very large inchondromas that will need reduction. It's not very frequent, and we most of the time try to avoid these surgeries, but sometimes if we have a very big inchondroma someplace, we have to take it out. The only thing is this surgery is often difficult, and there's a lot of bleeding, so it has to be very careful, but it's possible to do. In the